I don't think Ron Nichols per se needs much introduction. As the director of Chambers County EMS in Texas, and I'll let you, Ron, tell more about your background if you want. But Ron has really been on the front line and the vanguard of a lot of things really in the past year and before that. He's done some really fascinating things with respect to working as a group with neighboring agencies and sort of trying to make sure that everybody has the resources that they need. He's managed to turn over boulders to find resources and sort of pile drive through some drywall to get what needed done, particularly with respect to COVID-19 and whatnot. And one of those things is his vision for being able to provide care wherever patients are. I think some of that is a function of being a rural service, but also, the role that he's taken and gotten and earned for himself and for his department at the state level in Texas, which I'm sure everybody knows can be complicated when it comes to law and process and procedures. So Ron Nichols, and we're all really interested to hear sort of how you made this work. You've been doing some remarkable work. I, for one, have been watching you do this for a long time, and I've been amazed. And I tend to see these types of programs in a lot of different places. You have gotten the puck far further down the court for the field than I think a lot of people have in a lot of places. So, Ron Nichols, take it away. Show is yours.
All right. So for those of you that don't know me, that I haven't had a conversation with, my name is Ron Nichols. I'm the Emergency Services Director for Chambers County EMS. I'm also the planning section chief in the EOC, and I've got probably 5 different hats that I wear here at the county outside of just my normal EMS chief hat, which is fun at times and other times not so much. But little background on me: I've been a paramedic since 2005. I got my EMS certification in 2005, became paramedic 2006. A week after I got my certification, I was a contract worker for Hurricane Katrina. And went to Hurricane Katrina to provide services to Hurricane Katrina. I've worked every major hurricane in Texas since that time in one form or another, whether it be from a medic on the street to the last 4 that we've had here in Texas. I was the operations or the planning section chief for the local EOC, or I was the IC on the ground for Harvey, which was entertaining as well. So I worked in the city of Beaumont, which is a very active 911 service, runs about 20,000 calls a year. And got hammered and learned how to be a paramedic pretty quick in the city of Beaumont. But one of the things that I've always strived at doing was providing the best services I can provide to my patients. So my entire career, my patients had my cell phone number, especially if it was patients that needed additional help, and I would provide them additional services outside of my regular job duties at the city of Beaumont EMS as being a field training officer. The community paramedic thing, when it started coming around about 18 years ago, I thought it was a great opportunity for us as a career to move our clinicians forward and show everybody what we can do as paramedics and what we can do as EMS to help our communities and solve those healthcare boundaries and help people get past those boundaries on healthcare. So I've been a huge advocate for community paramedic. I've talked to multiple programs throughout the country, especially here in the state recently, and have strive to ensure that those programs become available anywhere that you need them, especially in the rural environment where access to healthcare is not the greatest thing. Chambers County, we're strategically located between Jefferson County and Harris County. So everybody hears about the city of Houston, and everybody hears about Harris County on the news. During any major disasters, or especially during COVID, they always hear about Beaumont and Jefferson County. We kind of get left out in the middle. We've got the Texas Medical Center 75 miles away. But you know as well as I do, 75 miles is not an easy trek for people to get to when it comes to healthcare. So some of the things that I've done in the last year, besides COVID, is our community paramedic program. We started Chambers County EMS. I was hired in October of 2019 to combine 3 EMS services into one EMS county-run third-party service. I managed to get a license in about 6 months, which is kind of unheard of in the state of Texas. And then we got our license within the service March 31st of 2020. So in the middle of the pandemic, within 2 weeks of the pandemic starting is when we got our EMS license and brought in 18 different people from across the state to combine an EMS service and go in service and start in the middle of the pandemic. So our community paramedic program is not completely off the ground and running at Chambers County. We're still pushing for that. But what we did is we did a modified community paramedic program. We used that to do follow-ups on patients that didn't get transported to the hospitals. We used that to do our mobile vaccination clinic. To date, we've done 597 in-home vaccinations for residents in Chambers County in the last 3 months. Actually going in their house and giving them their shots and using our community paramedic program and our state's 211 list in order to make contact with those patients and provide them that access. These are all 65 and older, patients that have autism, patients that have, some form of mental disabilities, bedbound, can't travel, wherever the situation is. We were also contracted through a couple hospice services to provide their hospice patients the shots, and they paid us to do that as well. So one of the biggest things, and one of the reasons Jonathan wanted me to talk is recently, we're currently in the legislative session for the state of Texas, just like you are in most states across. And I've been very involved with our local legislatures on getting a couple bills. We fought a couple, and we've had a couple that we got pushed through. We're lucky in Texas that we have the Texas Ams Association, which is basically a large part of EMS chiefs and fire chiefs from around the state that all rally together and basically do our own lobbying organization. We're not a lobbying organization. We're advocates, and we advocate for certain bills and advocate for things that are best for EMS as a whole in the state of Texas. You do that by networking, just like anything else. We all have conversations. We talk to our partners. We talk to hospitals. We're already used to doing that anyway. But for some reason in EMS, and I still don't understand it. I'm still trying to figure out. We have a hard time actually trying to get over that boundary and actually pick up the phone and make phone calls to our state legislatures, to our local county commissioners, county judges, mayors, whoever. And we don't do that as an organization or as a whole. But one of the things that we did as a group is we basically wrote a law or that we developed and pushed through some of the state congressmen. It's House Bill 3180. I think it's 3180. Sorry. House Bill 3180, which is basically what it is designed for. It is designed for us to actually generate and create a funded option for community paramedicine in the state of Texas. 3171, sorry. Trying to find the bill so I can pull it up for you. So did you give me access to share my screen, Jonathan?
I certainly can. I don't know if I don't know how to do that without making you the host. So you may
that's fine. If you make me a host, I can make it work too.
Yeah, you may start getting asked for people to join the meeting. So if that becomes an issue, just let me know.
That's fine.
Okay. By the way, carry on, and then I've also got a list of a couple questions that I may prompt you
you're fine.
as we go. Turn.
I don't know if you can see my screen. I hope you can, but this is House Bill 3161. It's currently waiting to go to the Senate for review. And this is a bill that is entitled and was written by paramedics from across the state that was submitted through the state government to go into the House and actually become a law, which will establish community paramedic programs to coordinate healthcare services and improve healthcare provisions. So basically, this establishes a community paramedic program as a known thing in the state of Texas, and it gives third party. We started out with third party EMS services, but it gives municipalities and county governments access to create a community paramedic program, get funding from the state to do those programs, and also allows us to bridge that gap. Everybody who's been involved in community paramedic or mobile integrated healthcare knows that sometimes you have a hard time getting doctors and nurses and everybody else on board with what we do because they look at it as a conflict because it could decrease their compensation or it could cost them money or whatever the situation is. So sometimes you have those hurdles. This actually puts a law in the books in order for us to, and that's if it makes it through the Senate. That they have until tomorrow to actually put it on the calendar. Hopefully we're making some phone calls and stuff today to push for them to put it on the calendar. But that hopefully they'll put it on the calendar. I'll put a link in it, a link to that in the, well, look, Jonathan already did. I'll put a link for it in the chat so y'all can pull it up and actually read it. The biggest thing, and one of the biggest things to talk about besides the networking part, is the language. So one of the biggest issues and hurdles that you have talking to your legislative session and talking to your state senators and congressmen or even your nationals, I've had conversations with Ted Cruz. even your actual, senators that are in Washington and congressmen that are in Washington is the language that you use. In healthcare, we have a tendency to speak in healthcare language, right? Everything we talk about and everything we do is based on what we're used to talking about. But when you're talking to a politician who's a business guy or something to that effect, or who doesn't know anything about what we do in the healthcare industry, they get confused and they lose interest. So language, a prime example, me and Jonathan have had this conversation several times. We as an industry use reimbursement as our language when we're talking to people. We need to shift away from that language. If you're talking to, when I was talking to Mays Middleton, who's my local representative for the area, and I was talking about reimbursements, I switched the language, said, hey, we're trying to work on our compensation. Everything we do, everything you do in business, you get compensated for, right? It's revenue, it's compensation. So we use the language of compensation, and it kind of piques the interest a little bit more. And by using that language, they have a better understanding of what you're talking about, because now I can show, well, look, if we're doing 15 visits a week to these 7 patients, and those 15 visits have resulted in them not being admitted to the hospital or getting them to their doctor's appointments or doing the things that we're doing, I should be compensated for that 30-minute window for those 15 visits. So if we're doing this many visits, we should be compensated for that, right? It's not revenue, it's compensation. We're being compensated for service that we're providing. Not any different than a doctor's office, not any different than a physical therapist or anybody else. And of course, you have to fight up against the insurance companies, which everybody knows is not fun either. So, but language is the big thing. And so for us, that was the thing we did. Also, language of the bills. How do you know what the language is to actually write a law, right? I had no idea what it was. What I knew is I contacted people that were smarter than me, aides and stuff like that, and said, hey, if I wanted to write a bill, what's the best way to make sure that it captures your attention and gives you an idea of what I'm asking for that gets, so.
Let me pause you there for a second, Ron, because that was actually one of the questions I wanted to make sure we covered. The actual mechanics of how you learned how to do that, who you talked to. Can you tell a little bit? You said, it sounds like you said aides.
So the best, two things we did. One is we pulled a bunch of bills that would come through the last legislative session. Anything that had to do with medical, anything that had to do with insurance, anything that had to do with something that was going to affect us. There was about 3 or 4 of us that did it. We pulled all of those bills and started reading those bills and how the wording was written. So we had a better idea of how to make the language fit the way that they would understand it and to make sure it fit what we needed as well. So that was the start. The second part is every single state senator, every single state representative, every single, congressman, every single national senator have aides that are local that work for you, an office somewhere around you, right? Those aides are very helpful in having conversations with them. One, because they're the ones you're going to talk to before you get to talk to that senator or that representative. So that's one. And two, they're the ones that do all of this, right? The senators don't write these bills and then submit them to the House or submit them to the Senate, right? Their aides do that. Their legal clerks do that. That's who you go through. Talk to your local law school. We reached out to one of the local law schools in Houston and asked for somebody for some of their law clerks to help us with these bills and how to write those laws. And they got credit for that through their law school program, right? But they're also helping us do what we need to do and giving us that information that we need so that we can make sure that we're having those conversations, because most of those aides are lawyers. They've been to law school, they've been to business school. So that's what they're used to doing. And it also gives them the experience. Now they're helping us do something, and then they get to take it back to class and get credit for it as one of their projects. So we reached out and did that. And those are the kind of things that you just kind of have to do. But the first step is this. I don't know if you can see it, my cell phone. Oh, look, that's like a picture of me in a suit. That's the first step, all right? And what I mean by that is between email and phone calls, you actually have to pick up the phone and make a phone call. And if you don't do that, you're never going to get to the point where you can actually accomplish something. And not phone calls, my first phone call when we were working on this project was to my county judge. So unfortunately for me, the county judge is my boss, so it makes it a little bit easier. I talk to him on a regular basis. I already have that rapport built with him. But I called him and said, hey, I'm working on these 2 bills for next legislative station. Can you get me in contact with Mays Middleton and Brandon Creighton and Dade Phelan, since they all are our local representatives, because you talk to them on a regular basis, right? Because they have to deal with them on a regular basis. Can you give me contact information for their aides so I can make some phone calls? They gave me those phone numbers, and I make those phone calls. And then as you talk to them, they refer you to somebody else on their committee. Well, talk to this senator because he's on this committee as well. And then you start making the phone calls to the different committee that's doing that. And then you get them all engaged. And the next thing you know, after we did that, we had 5 of them. Then we did the same thing we're doing right now. Next thing we know, we're having a Zoom meeting with 5 different state congressmen, state representatives to have a discussion about a bill that we're trying to advocate for that are all on the same committee. And then once we did that, then you all start getting invited to Austin. I don't like going to Austin. I don't like Austin. I'm a South Texas boy, right? Southeast Texas. I like the country, so I don't like the city. I don't like going to Houston for that matter. But it's part of the job, suits and ties and all of that good stuff too. Then you start going to Austin and next thing you know, you're getting phone calls from other EMS chiefs and through the association to go have conversations with senators and representatives in Austin. Because that's another big thing that I have on my calendar. I'm a government employee, right? I work for the county. I'm a department head for the county, for Chambers County, and I work for the county. So in Texas, it's against the law for me to lobby, right? Because I'm a government employee. But it's not against the law for me to advocate. That's the biggest difference. So that's another terminology thing, right? I mean, what's the difference between lobbying and advocating? Well, I don't collect money to go to Austin to do all the things. I do it on my own time. I do it burning my vacation time. I'm not getting paid and compensated for doing that, right? So it's me advocating and having conversations with senators and making phone calls and doing those things. I'm just there advocating what's best for EMS as a whole, or advocating what's best for whatever bill that they're going through. One of the big fights we have right now, and thank God we won, but they had SB 999 that came through legislative session this year. And as an EMS organizations, it would have killed us. The big push for the last 2 legislative sessions in Texas is to take the patient out of the middle of billing. So one of the senators decided to put SB 999 out there, which was a basically way to end balanced billing and get rid of balanced billing for all EMS services in the state of Texas. And also, in order for us to do balanced bidding, we would have to go through unrestricted arbitration. I don't know if anybody's been through arbitration when it comes to insurance companies, but that's pretty bad. We fought it and we got it changed to where they're going to do a study instead. In the study, they're going to study EMS billing and balanced billing and stuff over the next 2 years and bring it back to the next legislative session. We as EMS services and EMS chiefs across the state basically started rallying behind each other and started using our contacts to send those emails to the state senators, representatives, tell them how bad of an idea this was. And just like anything else, I mean, look at our fire unions. Tony's been a fire chief and he's worked in fire for a long time. Everybody's been in fire. They all have their unions, right? Their unions advocate for you. Their unions advocate for them to get what they think they need, right? EMS, we don't necessarily have unions. So what we do is we did the same thing. We started making contacts. With each other, especially when COVID started. I mean, kind of how comp got started, right? It was a bunch of people that were like-minded that decided, hey, we need to start having this conversation. We have more downtime, so we can have this conversation now, right? Doing the Zoom meetings. We did the same thing. All of our regional EMS leaders from around the Houston Cetrac region, there's about 75 of us. We're doing weekly conference calls to discuss what policies and procedures we were putting in place, how we were going to manage COVID, how we were going to manage and share PPE. We did that as the EMS and fire chiefs from around the region and had weekly conference calls to discuss that. And then when these bills start coming out, well, then I've got that comp list, or I've got that department, that EMS chief list. Hey, I need your guys' help with this. Can you start calling your senators? And oh, by the way, here's their contact email for you to contact them because I've already talked to them before. And then they start sending those emails. Well, like on SB 999, when you have 357 fire and EMS chiefs from around the state email all the state senators and to tell them how bad of an idea this is, they start paying attention to that. So then Dade Phelan, who's the Speaker of the House, contacted TIMSA, which is our advocation association we have to the state of Texas, and said, hey, start emailing all your people and CC my aide so I can see all of these emails. That's how we got that bill shut down, was by doing it that way. And it's by advocating and using our network, using the relationships that we already have. We all go to conferences, right? We all go to conferences to learn stuff, but most of us go to conferences so we can visit our friends that we haven't seen in years and people that you talk to. I have a Rolodex with probably 97 different business cards in it. There's a business card in there I'll probably never look at, but that one time I need it, it's right there, right? It's that contact that I've made at some point in my life that allows me to get where I am. I wouldn't be where I am without the networking that I've done and without the conversations that I've had with people and without having those people that I can lean on to help teach me X, Y, and Z, right? So that's where the networking comes into play, and that's where the advocacy comes into play, is to make sure you build those relationships and then utilize those relationships to push your agenda for all intents and purposes, which we've gotten very well at doing that in the last 5 to 6 years in the state of Texas, where we weren't able to do that before. So that's kind of my story and kind of what I did. And like I said, I apologize, I don't have a nice, pretty presentation for you guys. It's more going to be, it was more planned to do kind of a conversation about what I did and do a question and answer at the end. Was more of what I would plan for. And I did plan to have a nice, pretty presentation, but I was in the hospital in the ICU for 2 days with my mom, so that kind of slowed me down on getting caught up for the week. So I didn't want to cancel it because we'd already been pushing for us to do it. So I told Jonathan just leave it scheduled. So
I think we can forgive you for that. I got a couple questions for you that I kind of want to lead you to a little bit of a layer of detail that I hope you can elaborate on. And yes, I would agree. We all hope your mom's feeling better. Glad to hear she's been. So a couple of the things that I had written down, you've touched on a little bit. Mentioned the one was the mechanics of how you learned to write it. I also had written down here, you said you managed to bring fire and EMS together, which of course has been a political challenge in a lot of places. And I think if you can expound on that a little bit, that'd be great. But two sort of mechanical questions. Again, I want to make sure that one of the things we get from today is a takeaway for folks who are looking to try to do what you've done elsewhere. Right, because I think you've really achieved some a measurable success. Clearly, even in getting to this point, as you mentioned, there's still steps to go, but you're further along than a lot of places. People have been working a long time to try to get to where you are. So you started the conversation by mentioning how efficiently you managed to get even the license for your service, right, and sort of the actual paperwork and the red tape basically that you cut through. Of course there's a lot of red tape in this business. So if you can sort of explain on the one hand, mechanically, how you managed to achieve some of those processes as efficiently as you did, that's one. And the second part, you also, in almost the same breath at the top of your presentation, mentioned that you were, for example, you got in people's homes, you're getting paid to do those shots, for example, beyond anything like roster billing that sort of came down from the Fed. To whatever degree you have managed to demonstrate to people in your community that your work is worth compensating. If you can sort of talk to what metrics, what language, as you mentioned, which I think is amazing and wonderful, by the way, but sort of what did you do to on the one hand get through the red tape, on the other hand convince people that it's worth stepping up to that plate with you and liaising with you that closely? And I think that'll probably take us into some audience questions after that.
Well, as far as like the licensing and stuff and pushing that, I mean, it usually takes 9 to 12 months to get a license in the state of Texas. The contacts that I had made throughout my career with those state legislatures and things of that nature, I kind of cheated. I did all the paperwork, and all the paperwork was submitted, and it's usually about a 90 to 120-day process after you submit all your paperwork, which was submitted in January for you to actually get a license. And I used COVID to my advantage, and I called my state senator and said, hey, look, I've got 3 part-time EMS services. There's EMS services around the state that are restricting part-time employees from working. I need this license now and not tomorrow so that I can make sure that we're providing service to the citizens of the state of Texas. That led to contacting Chief Kidd, who led to contacting Joe Smeeter, the state EMS director, who led to me getting a phone call 2 days later saying, hey, we're coming to do your inspection tomorrow so we can get you licensed. But that's those contacts and that networking is what led me to be able to do that. COVID.
It sounds like, I mean, in almost in no uncertain terms, and I realize this may not be a word that everybody loves, but you kind of were in sales, basically, right? I mean, you had to sell you and the value proposition, the community, the concept.
Yeah. Everything we do is EMS chiefs and EMS directors, community paramedics. Everything we do is sales. I mean, and that's a good point. I mean, you have to sell yourself. You have to sell the need for yourself, and you have to sell that you're going to do and advocate and do what's best for your patients, because you have to build trust. and you have to build respect, and respect is earned, not given, and it never has been, regardless of what people think. You have to earn the respect of certain people, and then now those people in turn talk good about you, which generates more respect and more advocacy, and then you start making more contacts. The advantage we had with a lot of things that we've been able to accomplish this year is because of COVID, and it's not because of anything else. It's because of the pandemic. The pandemic opened people's eyes to the value of telemedicine. It opened people's eyes to the value and the trust. Prior to the pandemic, EMS is not a trusted thing. It's just something that people expected. They didn't understand what we did and why we do it. They just thought if I had pain, I call 911 and an ambulance shows up and takes me to the hospital and gives me a ride, right? People have found out through COVID that EMS is a very trusted healthcare organization within our country, and it's something that's around the world that has gained a lot more respect, especially because we were on the front lines, the same as those nurses, the same as those doctors, the same as those firemen, the same as those police officers. We're doing the same exact job they are at an even more riskier level because we're doing it in a confined space in the back of a little box, right? I mean, if I got a COVID patient in the back of my ambulance, I'm in a confined space. We're in a rural environment. We have 30, 45-minute transport times. That's a prolonged exposure, right? So we use that to our advantage. We contact the local doctor. One of the advantages I have is Dr. Redmond is my medical director. Dr. Redmond is a family practice physician. He doesn't have the trauma and the major ER and the medical background, which everybody thought was a bad idea, right? But why did I do that? Why did I make Dr. Redmond medical director? Because he's local. He's the medical director of the local hospital. He runs the local family practice clinic, right? So he knows this community inside and out. He has those contacts. He has those people. Hey, Dr. Redmond, we need to start pushing and taking care of these patients. We can't transport them all to the hospital and overload them. Can you start helping me get some information about, start giving me information on the patients you want us to contact to go out and see, to do follow-up on. I mean, I get emails from Dr. Redmond's clinic 2 or 3 times a week. Hey, you need to add these patients to your community paramedic program and go visit them because we can't get them in the office because of COVID restrictions. That's how our community paramedic program started. Then we started doing the telemedicine stuff, which made it even better. Everybody's got tablets and computers on their trucks, right? Most everybody has Wi-Fi built into it. They've got cell phones. We've got computers that we hold in our hand. So getting access to that's the downfall for us is in a rural county. About half my county doesn't have cell phone coverage. So doing telemedicine is not the easiest thing in the world to do for us. But what we started doing was the patients that we'd put them in the back of the ambulance, not because we needed to assess them in the back of the ambulance, but because I have cradle points with SIM cards that have these ginormous antennas on the top of my truck, which gave me extra cell phone service. So our home visits were done in the back of the ambulance because it gave us access to have Wi-Fi access and access to a cellular network to make those phone calls and do those telemedicine calls and do those things. So it's utilizing resources you have. And by us doing all of that stuff, we started building a pretty solid reputation within Chambers County pretty quickly because, we went out and said hi to Mama Jones, for example, right? And checked on her after she decided not to go to the hospital. We did a follow-up the next day. And then she calls her three friends that she plays Bonko with, and they're all calling us, asking us to come out and visit them, right? I mean, that's how that works. That's where the networking starts. And it's thinking outside the box. When you talk about the fire and EMS and bringing fire and EMS together, we all have the same goals, right? Outside of the fact that we're going to fight over the same budget money and we're going to do those things. Fire and EMS chiefs, they all have the same goals and they all have the same directions, and we all have the same missions for all intents and purposes. So for us, it's more of, hey, what do we need to do to help you get to where you want to get? Show them that I can help them first, and then that fire chief is more than happy to help you out because you just helped them solve a problem that they may not have known how to solve. And it's asking that question. That's kind of how that works. Did that answer your question without going off the rails?
Yeah, that was phenomenal. And like I said, just the last bit I'm hoping you'll touch on. Again, you mentioned the process by which you managed to get people to part with their cash on your behalf. You talk a little bit about that, and then Beth McCall had some questions and thoughts. I want to make sure. So she's
so as far as the compensation side of it, what I did is besides the roster billing stuff, you guys know we already had that conversation. I was one of the first people in the state of Texas to actually get that accomplished for the roster billing side of it, and now we're set up to actually roster bill and get paid for all of our flu vaccinations and Tdap vaccinations and any other vaccinations we're given that are coming up. But for us, it was, we're in a rural environment, and we're there in the middle of COVID. And what ended up happening for us is a lot of the local nurses that were doing home health and hospice, they took the money. And what I mean by that is for us, a lot of them took those contract jobs to go to New York and go to those other places, and it started leaving the home health and some of the hospice organizations a little bit short-staffed. And so I made those phone calls and said, hey, who do I need to talk to in your accounting department? And they're like, well, what do you mean? I said, well, I just need to talk to somebody in your accounting department to figure out exactly, what kind of assistance y'all need from us. Okay. And so then you get a hold of the people. I got a hold of the people in the accounting department and said, hey, how much money are you losing because of your lack of nurses? And the fact that you're now having a nurse that has to go 2.5 hours to see a patient versus one that was local. So you get them talking about money. They're like, hey, well, what if I could help you get some of that money back and save you money in the long run as well by providing you X, Y, and Z service? Well, what kind of service can you provide? Well, we've got a small community paramedic program. So if your nurse is 2 hours away, you call my EMS organization, we're going to send out our community paramedic that's going to go check on that patient for you. And they'll call and give a report to your nurse and let your nurse if they need to keep coming or not. And we're only going to charge you $75 for doing that. Well, I know how much hospice gets paid on a monthly basis to take care of their patients because I look it up, right? They make an average of $8,500 a month for one patient. They're providing all those services for that. So $75 for them is nothing. But it also saves them the money they're paying that nurse. It saves them the mileage they're paying for that nurse to drive in her own car. It's saving them that 4 hours of time for the 1.5-hour drive each way, plus the hour they're going to spend with the patient, plus the per diem rates they're paying. Now you're paying me, who's already in town anyway, $75 to do the same thing. And then when we did that, we're like, hey, by the way, we've got these vaccines available. Do you want us to give these shots to your patients? We'll charge you the same administrative fee that CMS pays. Oh, absolutely. That's one less thing I have to worry about. So yeah, here's a list of my 27 patients. Can you go give them all shots? Yeah, we'll get them on the schedule this week. We'll send you a roster and then you just pay us, just like we would for CMS. We went and gave those 27 shots that week, and I had my compensation check about a week and a half later that was deposited in the county's account. When you start having those conversations about your community paramedic programs and your compensation, the first people to talk to are the people that deal with the money, and talk to them about their accounting practices and make sure that because once you get them talking about money, then it gives you a better idea of what services I can provide to you to help you save some money and put more compensation in your pocket, but it also gives me an idea of what I need to work on for me as well. That's where those conversations need to start.
Amazing. The amount of wisdom there, that's extremely practical, I think, to everybody on this call and everybody we know we talk to. Thank you, Ron. That's just incredible. And certainly trying to take notes. I'm really glad that we're recording the session so we can have this wisdom for posterity. So I see that Tony raised his hand. Let's go to Beth first, and then Tony, you're up after that. Beth, you on? Can you hear me?
I'm good. And I'll apologize in advance if my dogs bark because God forbid the grass grows. So
I have 7 of them, so I'm never going to apologize for a dog barking. I'm just on that.
Yeah, I have 3 here. So, and anytime anybody walks by, God forbid. So my question was, my first question was, did you already have an existing CP program when you managed to start getting the reimbursement, or did you develop the entire program from the ground up?
So when my job prior to Chambers County EMS, I was the director of Winnie Stoll EMS, which is a small 501c3 organization in Winnie, Texas. And I actually developed and started my own and the first community paramedic program in our region for Winnie Stoll EMS. So that was done with a lot of hard work from the ground and learning as I went and making lots of phone calls and getting lots of questions and opinions because it's a small rural community. It's got about 5,100 people. The local hospital is privately owned. So for them, all I was doing was trying to take money from them. So there was a big fight from the beginning. But in Chambers County, there was before I got to Chambers County, a community paramedic program was something that nobody knew anything about and didn't even see what the need was for it. So it's something we actually had to build. When I took over in Chambers County, because I'd already built the one in Winnie, it just made it easier for me to make those same contacts and start having those conversations saying, now I can provide it to you on a larger scale. And I'm actually in the process right now of talking to some other EMS directors, and we're actually building a regional community paramedic program to cover our entire region. And hopefully we'll have that off the ground and running in the next year or so.
Awesome, thank you. Yeah, I'm asking because locally, I'm actually suburban, but with where I work, we handle 11 districts or 11 townships, and a very busy little city, which has like super high crime rates and drug problems and that sort of thing. So I'm actually trying to put a program together locally. There's other programs that exist at 2 other hospitals in our region, but I'm trying to make this one a little more comprehensive than what they're doing. Basically, they're working on just the high risk for readmission technique, which definitely we need where we're at as well. But we're also starting to get involved in some community outreach, and I'm trying to get this developed a little bit further. And I don't know, and it's actually going to be my capstone for my master's. So I'm kind of like looking for all kinds of input just to see, because I'm in Pennsylvania, so obviously the legislation is a little different here.
So the 2 big things that everybody always starts out with is your frequent flyers and your high risk readmissions. Now, what I will tell you is from experience and from talking to different community paramedic programs across the country, your high risk readmissions is not something for you to even really focus on initially when you're starting, because that's got to come from the hospital side. But the problem with the high risk readmissions is that even though there's a penalty, this is from knowing the industry and how it works, even though there's a penalty from CMS for those high risk readmissions, you end up paying a penalty. You still make more money off the readmission than you would if you don't readmit them in the first place. And most hospitals are set up to do what? Make money. They're not set up to lose money. So I'll pay a small 10% penalty for a CMS patient that I had to readmit 30, within that 30 days, because that readmission of 7 days is still going to make me 30% more than I'm paying for the fine anyway. So you're going to get a lot of back. You end up getting a lot of hospitals that fight you on that, because their accountants and the people that count the numbers know the difference, and so they'll fight you on trying to develop your program for that alone. What we started with was more of the fall prevention side, the community outreach side. We started with fall prevention. Everybody wants to do fall prevention. Even hospitals get on board with that on fall prevention stuff. And we utilize that in our the opioid crisis, obviously, for the mental health awareness and for the that's what we focused our programs on when we started, which helped us build out to the hospice and the home health programs and the other things that we function on. My contracts are not necessarily with the hospitals, because the hospitals will send me patients they want me to follow up on, but most of the people that we get are through local referrals, or they're through Blue Cross Blue Shield.
Thank you very much. I appreciate it. Yeah, technology-wise, we're still a little bit limited in the field, although we're actually going to be getting third eye technology. I'm not sure if you're familiar with that. They're basically like video glasses, and it will allow us to do some telemedicine and hopefully figure out how to get reimbursement. Is that something that would probably fall under what you were doing with the telemedicine, where you get them to come out to the ambulance and be assessed?
Yeah, so the telemedicine side of it, as far as the EMS side, with you guys that work in hospitals, it's not an issue for you, because you automatically have payment set up for that. EMS does not. We have CMS has finally come out with ET3, but ET3 is not really the greatest thing in the world if you actually dig into it on how it works. So for us, what we did is we partnered with the local doctor's office for the telemedicine side. So, Dr. Redmond, we're going to set up a telemedicine call. Well, he gets to bill for that through his office, right? Whatever the fee is that he gets to bill for that telemedicine call. And I think it's like don't quote me on that, but I think it's like $75 is what he gets to bill for that. So since we're providing you that patient, we're providing you that service to make that revenue. It's not costing you anything except for pulling up your tablet when I call you on a scheduled appointment. Give me 15% of whatever you're collecting off that telemedicine call. And so once a month, whatever the telemedicine calls, they'll provide us a check that comes to us for our compensation for giving them access to that patient that they wouldn't have had before. And they can make a lot more money off the telemedicine calls than they can trying to get all these patients shuffled into their office and trying to get it, because that's what everybody's found out through COVID, through all the videos and all of the teleconferences and everything we do. I can get a lot more accomplished and see a lot more patients doing it this way than I could in my clinic. And so they're more than happy to do that, because now I'm giving you access to 7 or 8 or 9 more patients a month that you wouldn't have had before.
Yeah, I agree. And we actually had a family physician on board. We were hoping to start evolving this, and then COVID hit us like a ton of bricks, because we're just outside the Philadelphia region, and we are hospital based. So it hit us hard around here. So, very good. Thank you so much.
You're welcome.
Awesome. Thank you, Beth. So we've got 3 questions lined up. Order is Tony, then Victoria, and then Ed.
Before I go to Ron, Beth, what county are you in Pennsylvania?
I'm actually in Delaware County, which is about 20 minutes south and west of Philadelphia.
I worked at Bucks. I was at PCOM today doing some extrication training. So.
Oh, no kidding. Okay.
We'll have to catch up, because I could talk to you about some of the frustrations in Bucks, and maybe help you along with Ron's information.
Are you in Bucks County?
Yeah, I was. I'm
Okay.
looking back on the street, so who knows? I might end up in Delaware County.
Yeah, I'm actually a lieutenant for Crozier EMS.
Okay.
And Crozier is very supportive of our community outreach efforts. And I'm sorry I don't have my camera up. I came off night shift and I look like hell. So, but yeah, they were very supportive, and we started doing some outreach in the form of flu shots, COVID vaccinations. Even throughout the winter, we were setting the disadvantaged up with food, clothing, winter coats, the homeless population. We were setting them up with sleeping bags, because all the local shelters were running at 50%. So it was a really tough situation for our people around here. Yeah, so we started getting that out, and our North Division has a huge, obviously the opioid crisis is very bad, but where they're at in the North Division, they have the 69th Street Terminal, and I did go up there, and the number of overdoses that they see every day is just insane.
Awesome. Yeah, I'll catch you offline. Jonathan, maybe if somebody could put my email, because you guys did this right. I only got 4 minutes, so you get rid of me really quick. One, Ron and Chambers County are exactly the reason that comp was started, to do all the things that Ron's doing. And so I think, Ron, what you're doing, and I know there's others of us that are doing some, but honestly, we should put together a program, a class. It could be 2-3 days of the micro and macro of getting programs started. And I'm glad you used compensation, because I know we put that paper together early in comp. But one of the other things, I think that we should be changing the term, keep working harder to change the term to mobile medicine, mobile integrated medicine, because one of the things that politicians, and I know you'll agree, they like to see what's in it for them. And I know in New Jersey, the legislation that we did get passed, it had to be, was public safety benefit. In other words, it benefited the community. Our political equity was beneficial. It wasn't we were looking for political equity. We used to have the New Jersey, well, we do, it's just not operate. New Jersey Fire and EMS Institute. Pennsylvania has PEMSI, both which, well, PEMSI is much more active, but I would suggest other states that want to do something like Ron to also look into those institutes that combine fire and EMS for common ground type of issues. And with that, Ron, do you think, part of the terminology, like you said, changing it to mobile integrated health instead of EMS, because EMS paints a connotation of ambulance drivers and stretcher bearers type of thing, helps along with changing the compensation, which we've been trying to do as part of comp.
Changing it to mobile integrated healthcare is definitely the smartest move, because it shows that you're trying to integrate with other different techniques. I think the problem is, just like everything else we've had, is that even though mobile integrated healthcare is the terminology we should be using, people don't understand what you're talking about when you say that. When you say community paramedicine and you're talking about community paramedicine as what we do as a community paramedic, people have a better understanding of that versus trying to explain mobile integrated healthcare and the difference between the two. They And just like anything else, it's a language and it's a knowledge base. I think as an industry, if we tried to push that, one of the things we found too is people in certain hospitals in Texas don't like the mobile integrated healthcare program because now you're lumping them into it, and they don't want to have anything to do with community paramedic programs or mobile integrated healthcare programs. So that is another hurdle that we have to figure out on how to manage that situation. I know we do locally, well, you're not integrated with me, so why are you calling yourself an MIH program? I've run into that 2 or 3 times already in the last year.
So since I have to leave, I'm going to leave this, and you guys can, maybe we should be pushing, because I've heard it in other forums and other organizations, to get paramedic to be the term we're all called, and community paramedicine of what this service is, and we can somehow work on developing that mobile medical concept on top of it. But community paramedicine, probably, I agree with you, should be the term. In terminology, that's easy for the civilians to understand and that we can market. Again, great job, excellent what you're doing, and there definitely should be more sharing of this information. A lot of agencies, and just so you know, Beth, the same discussion kind of was happening some Bucks County medics yesterday, and they want to know why Pennsylvania is not moving forward. With that, I got to leave so I can go do tribal leadership and then integrated extrication with crew resource management. Talk to you later.
Thank you.
So Victoria, you're up, followed by Ed, and Martha, it looks like you had a comment as well. So we'll have you go up after Ed.
So I just have some commentary quickly. I think fantastic insight here. There's nods to like the training and the language of the bill that you produced, which helps with minimizing concern of liability that providers have around these models. There's insight to incorporating family physicians as medical directors. So there's a lot of benefit there. I do want to ask and comment on, is there an existing national like repository or summary of which states are more advanced in community paramedicine legislation? How are different states breaking it down versus paramedicine versus MIH? I feel like most people don't even know what their state legislation says and what they are allowed to do and what the structure is, and they don't know how that compares to other states. And so there could be benefit to some sort of comprehensive in one place. Here's how Florida ranks to Colorado, to Michigan, to North Carolina. Here's what the bills say. Here's what the teams are able to do based on that. Here's the differentiation between paramedicine and MIH. And then along with that, I definitely second, my comment was going to be that there would be benefit to having a toolkit and a task force within this entity that almost we could launch a team state by state to help recruit, to educate, give talking points. Here's the toolkit step by step of operationally what you should do in each state based on where your current legislation is. There's probably benefit to that. And then, from a getting people to care about it, what's stopping us from creating a grading system to say, here's how North Carolina is doing with their access to care legislation, and we could have, a multitude of objective data sets that give them a grading scale for paramedicine, mobile integrated health, access to care, health outcomes in underserved, et cetera. So there's lots of possibility there, I think. And I don't know if anybody has comment on it.
Yeah, there's so much there. I would actually, Victoria, propose in all seriousness that we use one of our next comp meetings, to start compiling that information. Martha was just mentioning her association's working on it too. There's been efforts on that in the past to try to put these things together. And one of the challenges, at least when they were done that I know of, is that they were moving targets, right? So some of the publications, the EMS World and GEMS type publications, were trying to do that as well. There was a variety of different state groups that tried to sort of get a high level. By the time they put out the information, it was already outdated. So having a toolkit, I think, would be amazing. And what I think maybe we could do together, as again, a very practical function of comp, is brainstorm what should be in that. I think, again, Ron's wisdom on this topic and his practical views on how to package things for the selling of the idea is incredibly prescient. then, you know, we can also talk, for example, about how you boil those ideas down into a one sheet that you can hand to a legislator who might have a short attention span. How you transfer that into 140 characters so you can advocate for it on social media. I think there's some very practical steps that we can talk about here. But we could do that for a while. Let's make that a topic in one of our future meetings and actually come up with some takeaways that we can assign people to do and noodle on and have, have an actual toolkit. Then we can respectively market those as well in our different organizations and practices and regions. Love that idea, Victoria. Thank you so much. Ed, I think you were next. And then Martha, I'm calling on you after that.
Sure, Jonathan, thank you for the invitation. Really great call here today. Nice to meet folks. I'm Ed. I only have one dog, but clearly I need a few more. And I spend my days trying to build healthcare systems that move healthcare data around the country a little more efficiently. I'm out here in Colorado and really appreciate your time today, Ron. Thanks for all this. This is great. I threw the question in the chat too, so folks can read along. But Ron, the question is, how do you balance the need of your emergency activities, those urgent calls that you have to do now, versus the community paramedicine, more of the scheduled time, the routine calls, the home visits, those immunizations, especially in a world where you have such a rural area and you've got, you know, half an hour to get anywhere? And can you speak to how ET3 doesn't help with that? Or is it because of the sort of the compensation of telemedicine? Can you double tap on that for me?
So ET3 doesn't help with that, because if you actually look at ET3 and you look at the way it's designed, when CMS enacted ET3, it's kind of a test program, right? But what they're doing is you're developing your own system, and you use your system, and then they're going to decide if they're going to compensate you for it or not. And you won't know until after the fact on whether or not I can put all the telemedicine stuff in place. I can do and meet all the requirements that are very they're very broad on what you can and can't do through ET3, but then CMS decides if they're going to compensate you for it or not on the back end. So you're putting out all the money up front. So ET3 is more going to be for those larger services like Acadian or Allegiance that have the money to try and see if it's going to work, if that makes sense. What I know, CMS just passed their waiver. They are paying for certain things for treatment non-transports currently. You're kind of using the ET3 model for that, but there's pretty significant hoops that you have to go through to even qualify for compensation through that as well, that the billing companies are working on right now. I have to have specific protocols for that. I have to link that it's completely related to COVID and nothing else. And it's just, is it worth messing with for a smaller service like mine, or just leaving it like it is? So it's not really, that's kind of how that works. And that's why we chose not to utilize ET3, because we just didn't think it was worth the headache. As far as managing the time, we have it set up two ways. So we have a dedicated medic that's what he does, is the CP program for us. Our community health paramedic is what we call him. We don't just go community paramedicine. We call it community health paramedic. That way we're still focusing on the health part. And that's what he does. He's the primary medic that does that. But see, I get out of the office and do it too. If it's in the middle of the night and he's not on duty, then if one of the patients calls, the on-duty crew goes, and then they call one of us to basically ask our opinion on whether or not he should be transported or not. The software we use Jonathan's software, which links in both, to give you an idea. So I can, for EMS, all of our charting systems are designed for one patient, one call, it's closed out, it's done, right? Now, we don't have the open charts with previous information like you would hospitals and everything else. So the software is key, and all the scheduling and all that stuff is done through Jonathan's software, through our TRIS module. So it makes it pretty easy for us. And then the medics, when they're running a regular 911 call, they can actually send us a referral for one of those patients that flags us for us to go back and schedule an appointment with them later through the CHP program. So that's kind of how that works.
Appreciate it. Thank you very much.
Mm-hmm.
Awesome. All right. I think as we're coming close to time, Martha, you are closing out the show. So Martha, thank you.
This was not planned.
certainly not least, but I will leave it to Martha and Ron to give us plenty to look forward to in the coming conversations. Take it away.
Thank you. Well, hi, everybody. I'm Martha Peribonio, and I am with the National Association of Mobile Integrated Healthcare Providers. Jonathan and I have talked a few times. Victoria and I have talked plenty, because Victoria is one of our Yesterday, we seated our board, and Victoria is one of our board members, so that is amazing. Yeah. So what the association, which is new, if you haven't heard of it, it's because it's new. It was formed in 2021. But a lot of the things you guys are talking about here today is what we're striving to do. I am by no means an expert as Ron is or Jonathan, but what I try to do is those connections that lots of the times what Ron says is the resistance to reach out for the phone and make that phone call. And it's probably most of the time, you guys can tell me it's because you don't have the time. You're out there running the calls, you're running the program. So the association was built to facilitate those conversations and say, hey, you know what, you need to talk to my friend Ron over in Texas, and I can get people together. We're building databases of programs around the country, whether there's more CP models, more MIH models. If you ask me, it's just what term you prefer to do, but we're all out there doing the same thing. And I've started trying to build the database of legislation. And yes, Jonathan, you're right, they're moving targets. So I think maybe the way we're going to attack that one is to try to actually have connections in each state, people like Ron, and who are very highly connected in each state, and then the information's funneling into the association, and it's there for other members of the association without somebody in Colorado having to do a lot of investigative process to see what's going on in Texas or Florida. They can all come to one place, and the association is getting that information and kind of farming it out and keeping it organized for the members, as well as helping with advocacy. And one of the big ones that I'm concentrating on is, I call it content creation, but basically educating everybody from the end user to the people in the hospital, like what is MIH, what is community paramedicine, what are the benefits for you and for the community. So getting a lot of people to talk, like sessions like this, Jonathan, are amazing, and putting that content out and just educating people, because even though it's been around for about 17 years, or, you know, others would say 10 or 15, others would say, this is totally brand new. I've never heard of this. What is it?
Wonderful. So did you have a question for Ron? I didn't know if it was, I thought it, just to close
No,
it
yes,
out.
I was just commenting and saying how valuable what he is doing is, and I am definitely going to be contacting you, Ron, and having a conversation on the phone with you. And I think, you know, that's what the association has to do is stay in contact with people like this and build the database. And hopefully with more people joining the association, then we're just connecting people across the country, because it is a big country and you all are really busy people.
Well, allow me to then plug as kind of a takeaway note here, because we do have some new faces on here, which has been wonderful today. What the Congress of Mobile Medical Professionals, of course, was intended to do is to be a big tent. And I think, so Martha, for example, the advocacy, the passion that you bring to exactly what you described that you're trying to accomplish, and really herd cats, right? Herd cats that are sometimes moving quite quickly and sometimes moving rather slowly. That I'm seeing Ed's face on screen here. I know he has the same, you have scars of doing similarly, I know, in the places where you operate. You know, what COMP was intended to do was to be a place where all of those different organizations could share their knowledge, right? The whole purpose of this, going back to the way we started and when we started, was this idea that we have all these different groups, kind of like spokes around a wheel, or a constellation, really, that didn't really touch one another, but would benefit from doing that. And so the idea was to try to be really a supersized tent, sort of a macro association that could incorporate all of the other associations too. So it's really the idea, going back to the beginning, was all comers are welcome. No matter where you are, no matter what your specific interest, there are lots of politics, and basically we all check them at the door. You know, again, Martha and sort of seeing you guys on here, but I know there have been, and Beth, I don't remember, I think this might be your first meeting with us as well, but we have had some extremely passionate conversations that ultimately all end up in the similar type of place, which is, thank goodness we had this conversation. And so what we are really trying to do is create occasions for people like Ron Nichols to share knowledge that others might not have heard about, because of whatever reason, whether because he's in a corner of Texas that doesn't get the same level of attention as Harris County, or Austin or Dallas, et cetera, or because in some cases, like I'm in California, we have many associations and different, you know, sometimes the prosciutto is sliced really thin, as I sometimes say, where, you know, depending on your interest group, there's an association and associated dues for every interest group. So what our goal here at Comp, just to sort of take this out, closing on the hour here, is to be a place where all those perspectives cross-pollinate one another, so that we can take Ron's wisdom and his accomplishments and have people, whether you're in Georgia or you're in Colorado, and be able to say, hey, how can I use that strategy in my own backyard? And so, Ron, I just want to thank you as a last note here, because you have done extraordinary work. Obviously, I've had the privilege of being able to see some of it sort of in the trenches with you, but there was a lot that led up to the position that you're in right now, and I think you have been really just today laid out some very concrete strategies that I think people can take away. I hope we will build on what Victoria suggested as well, and try to package that into some tasks and tools that, Martha, for example, you could give away to members of your association as an incentive for joining your association, and that sort of thing, and really have people move forward together, building on one another's strengths and efforts that we've all put into in different corners of the country. Okay, any final words from anyone? Otherwise, I will call it adjourn us for the day, and thank you all for your time. Going once, going twice. Sold to the silent ones. Mr. Nichols, amazing job. Thank you guys all for being here. Stay safe. Happy EMS week to everyone.
Yes. Happy EMS week. Thank y'all.